All right, good evening, guys. How's everyone doing? Good. My name is Pat Buckley. I'm going to talk tonight about femoroacetabular impingement. I'm a sports medicine surgeon, and I primarily work down in the wall area out of the wall office. So I look forward to kind of talking tonight. We got a good group, so any questions that come up, it can be pretty informal. Happy to answer them as we go through. And without further ado, we'll kind of get going. So I have no disclosures on this topic. Just by way of a little bit of background about me, I grew up in upstate New York in Elmira, which is up in the Finger Lakes area. I went to Villanova for undergrad, so been a proud Wildcat the last couple of years, getting a couple national championships for us. And then I went to Philadelphia for medical school as well as residency, doing that at the Rothman Institute. I went to Vail, Colorado for fellowship, went to the Stedman Clinic, and was able to learn with really a number of the leaders in the field of orthopedics. And then personally, it was also a great year. It's a picture of my wife and I. There was just a lot of great hiking and skiing that we were able to do out there. So we really had a lot of fun. But ultimately, we're East Coasters, and we've kind of have family here in this area. So we're excited to be back in New Jersey and back here at UOA. So a little bit of the outline for what we're going to try to accomplish tonight is first just to go over really what is femoroacetabular impingement, go through the etiology of how we think it develops. We'll kind of talk through the different clinical presentations and how to examine a patient who you suspect has FAI. Look through the imaging that we try to look at in order for these patients, and then really talk about the treatment options that we have, both operatively as well as non-operatively, and then what our outcomes are with those treatments. So very basically, I think FAI is actually one of the best named diagnoses in orthopedics, because when you break it down, it really tells you what it is. So the F is femoro, the A is acetabular, and the I is impingement. So really what it is, it tells you it's right there. It's an abnormal contact between the femur and the acetabulum. Usually this occurs in high flexion type activities. So this is a lot of times you'll have with hiking, going up and down stairs, long car rides, those kind of things. And we know that it can lead to damage to the labrum, damage to the cartilage of the hip, and there's some thought that this can be a predisposition and can lead to early arthritis. It's a relatively new diagnosis, so this is something that we've kind of started talking about, I'd say since the early 2000s. The article that kind of published this was in 2003. But it's something that most of us have heard about, and I'm sure you guys have all probably had athletes that have had this. Is that correct, that most of you have taken care of an athlete with this? So it's definitely something that is becoming more common and something that we're seeing and diagnosing more frequently. There's really three main types of FAI. The first is a more cam-based impingement, and really what this is an aspherical femoral head. That is kind of the proverbial square peg in a round hole. So as our proximal femurs develop, usually there should be an offset that happens as you, is this showing up? Yeah. As the proximal femur should have an offset and kind of comes down here with a nice concavity. A cam lesion, or kind of a cam morphology of the proximal femur, is more where this is convex here and you have a bump that develops in the proximal femur. Typically this is young athletic males that will have this, and as the femoral head comes up into flexion, it can cause injury to the acetabulum, injury to the labrum, and especially injury to the cartilage in that area. We measure this with something called the alpha angle, and we use the number of 55 as kind of the normal for this. But it's important to realize that although a patient may have symptoms and imaging like this on one side, it's pretty common that they have it on the other side as well. But that doesn't mean that they have symptoms on that side. So over 75% may have this morphology bilaterally, but their symptoms may not be present on both sides. Excuse me for 1 second. I'm just going to show you this video. I think kind of shows you this pretty well. And so this is an example of really the cam. If you look at this bump that develops in the proximal femur, that's the cam lesion that we see come up and then impinge onto the labrum, which is that circular structure here. And over time, over multiple repetitive activities, this is what really causes the damage to the cartilage and the damage to the labrum that we see with these patients. So this is kind of loading here. And it'll go through a couple different cycles, but I think this is helpful to three-dimensionally try to understand how really this works. So you can see that it causes damage to the cartilage, damage to the labrum, And the underlying etiology is really that additional bone that's present at the junction of the proximal femur. So the second type is pincer, and that's really more of the acetabular. The problem is more on the acetabular side. Typically that is more on the anterior superior aspect of the acetabulum, which is the cup side. I feel like when I talk about this in the office, I'm using my hands all day because I'm basically making a ball in a socket and trying to explain to patients what's going on. The pincer side is usually where you have more over coverage of the cup side, and as your femur comes up and you go through normal flexion activities, it comes up and it can impinge, causing usually more issues with the labrum. You can have cartilage injury. And typically the cartilage injury for pincer deformity is more on the contralateral side, or kind of the counter coup type injury, which is something we think a lot about with concussions, but we can also see it in the hip. And so I'll show you a video of that as well. So I think these videos help to really show us what's going on. So it's over coverage of the acetabulum, and then as the hip comes up into flexion, there's impingement between the acetabulum and the proximal femur. And over multiple years, over repetitive cycles, that impingement builds up and you can have damage to the labrum. And then if I kind of speed forward here a little bit, it'll show you kind of this counter coup injury where you can actually lever off of the femur as this hip will rotate up, and it can cause damage more in the counter coup mechanism in the posterior aspect. Okay? So those are the two basic problems that we're talking about this evening. You have cam and you have pincer. As with most things in medicine, it's not that black and white, and most of it is more of a mixed type picture. And so with patients, we usually see a little bit of both, and it's important to recognize that because we have to treat both of them when we see them. There's a lot of research that goes into trying to understand exactly what causes this bump, this cam deformity of the proximal femur. Unfortunately, the short answer is we don't know right now. There's some talk as to whether this is genetic. Could this be, certain patients have a genetic predisposition to this. There's certainly a lot of talk as well that this could be more from nurture, that over time, especially as we see patients specializing younger and younger and increasing their sport involvement at a younger age, that's affecting the growth plate of the proximal femur, and then that this cam deformity is a response to increased stress and increased forces that they're seeing there. We can see cam impingement with a missed SCFE, which stands for a slipped capital femoral epiphysis. We can see it with a number of adolescent activities, and ultimately when we look at these activities and we look at the intensity, we look at the amount of them, we look at different types of activities, we're starting to see that this could be a result of kind of overuse from an adolescent time period, but that hasn't been fully proven to this point. So I think that's still somewhat up for debate, but certainly the trend and what I'm seeing kind of in the literature is that that's suggesting that right now. There are certain activities, certainly hockey players, especially goalies, who have that butterfly type maneuver to get down to block a shot, do tend to have a lot of internal rotation, high flexion, and those are the activities that tend to produce this type of deformity. And this kind of goes through a little bit of the proximal femur and the growth plates that develop over time. So you can see in the top, this is what a normal growth plate would have for the femoral head. And you can see that there's a nice concavity that will develop. But in response to trauma, and again, we don't know how much that is. We don't have a dose relationship for this. But the thought is that in response to trauma, increased stress, especially as that growth plate is developing, that this cam deformity can develop. And ultimately, that's kind of the beginnings of what many think is ultimately what leads to arthritis down the road. And you can see that kind of here in the x-rays where you start out with really a normal offset, but as you have continued kind of irritation, stress, trauma, we don't know what that is during adolescence that can develop a cam, and that bump with high flexion can come up and cause damage to the labrum and damage to the cartilage. I think this is important because this identifies an area for us from prevention. As we see a lot of these athletes who come in, we want patients to play multiple sports. We want them to broaden the type of activities they're doing. We want them to cross-train. All of those things are things that allow their bodies to recover from the activities that they're doing and allow that repetitive injury from one activity over and over again 12 months out of the year to hopefully not end up causing problems like this down the road. So in summary, FAI is really an impingement between your proximal femur and the acetabulum. And ultimately, to address it, we have to really address both sides of that and try to understand both sides of the equation. Dr. Gons in 2003, as I kind of alluded to, is really the one who proposed impingement as a cause of hip pain in these young, active athletes. And ultimately, he's the one that kind of is helping to lead some of the research to try to understand if this is a precursor to arthritis that we're seeing for younger patients, 20, 30 years down the road. But ultimately, as many of us who take care of athletes who have hip pain, we realize that there's a number of other things, and there's a ton of overlapping structures that all can cause hip pain. People present with hip pain, but that doesn't mean that it's all from impingement. But it's important for us to really establish an algorithm and be able to evaluate all of these different causes of hip pain in addition to impingement. So, understanding if patients have radicular symptoms, understanding where their pain is, all are an important part of working these patients up. And ultimately, it goes back to the basis of what we do. What's their history? What's their physical exam? Typically, patients with impingement will present with pain predominantly in their groin. They often will kind of have this C-type picture where they'll describe pain around their hip. They can have compensatory weakness and pain in their buttock area, but pain should not be predominantly radicular. It should not be predominantly in their lower back. Typically, this is pain that's reproducible in their groin, and it's caused by activities that have high flexion type backgrounds to it. So, people who do a lot of stairs, a lot of hiking, climbing, hockey players, basketball players, all of these things that have been shown, and really every sport has athletes who have this. There's a lot of new data that look at pitchers and kind of the high flexion that they come up as they go through their stride, and that can affect injuries down the road in their arms, ulnar collateral ligament injuries, shoulders. So there's a lot of understanding that we're just kind of learning about the effect that femoral acetabular impingement can have throughout the body. You may see patients who have a family history of total hip replacement or have been diagnosed in the past with groin strains or adductor strains. All of these are things that as we are getting better at the diagnosis and understanding what these images are telling us, that we kind of more accurately can diagnose these patients. And then, again, physical exam is really important. Typically, these patients will have normal flexion and have pain-free motion of their hip, but when you go in and internally rotate their hip, that's what's going to cause them symptoms. And what that's doing biomechanically is you're bringing that proximal femur up to the acetabulum, and as you rotate it, you're basically engaging where that bump is into the socket side and causing pain and causing symptoms. And so that's really the best test to evaluate this is this flexion internal rotation test. We also will see asymmetry in a Faber test, which is kind of shown here in the bottom right. And I'm sorry, it's kind of cut off a little bit there, but as we ask patients to externally rotate and abduct their hip, most patients will have a pretty symmetric amount between their lateral femoral condyle and the bed. And if we kind of see a difference, which you can kind of see in the bottom right-hand corner, that's really a sign of a captured hip. So the muscles are not allowing that hip to move freely, and that's typically a result of intra-articular pathology that's causing that hip to be captured. So you can measure that. That can be something that you can objectively follow as you treat these patients and ultimately treat them with surgery. Again, looking at all of the other things that we talked about that could cause hip pain are important when you examine them. Straight leg raise, radicular symptoms, numbness, tingling, all of those are things that typically point you to the lower back, and these are things you guys know. And also, where they tender, they can have trochanteric bursitis in association with this, or it can be their predominant cause. These are all things that we look for in the exam to try to help parse out exactly what's going on and understand how we can help these patients. Next, we start with basic imaging. This is really something that every patient would get when they come in the office and have hip pain. I like to do an AP pelvis, a done view, and a false profile view, which I'll show you what those are. And then moving forward on top of that with more advanced imaging, MRI, CT scans, those are helpful, and a lot of patients present with those, but the vast majority of this can be diagnosed and really understood based on history, physical exam, in imaging or in x-rays. So again, on these x-rays, we have a number of measurements. Understanding the cup side or the acetabular side really helps us mostly with the center edge angle, and that'll help us determine whether the acetabular side is dysplastic or too shallow, or whether it's more of a pincer type deformity or has an overcoverage. On the done view, we can see an alpha angle, which you can see in the bottom right, and that really helps us to look at that asphericity of the proximal femur, and you can see the bump that proximal femur should fit right inside of that circle, and when it doesn't, those are what we identify as a cam deformity, and we can measure that with an alpha angle. So a simple AP pelvis is shown here, but to do it right, it takes a good radiologist, and how you do that is kind of shown here on the right. But first we want to understand, is our AP pelvis well aligned? Is it well rotated? Because we're going to take measurements off of this and we're going to make decisions on those, so we got to know that we have a good x-ray. From the AP pelvis, we can look at the anterior, the front part of the acetabulum. We can look at the posterior rim of the acetabulum, and ultimately it gives us an idea about the socket and whether or not that socket is tilted more towards the front or anteverted, tilted more towards the back or retroverted. And if it is retroverted, it makes us more worried about a pincer type impingement, because it puts the anterior superior part of the acetabulum more in line with the flexion of the hip. We can look at the ischial spines, which again give us an idea about the cup side. And these are all things that we can glean from a simple AP pelvis and really get an idea of a significant amount of the three-dimensional anatomy that this patient's hip is showing us. We also look at the joint space. So again, arthritis is something that we have to identify. These are patients that won't do as well with hip arthroscopy. And we can do these measurements that help us understand exactly what's going on. This done x-ray is kind of shown here. And again, this is what gives us a good idea about the alpha angle. And this is what helps us measure the cam deformity. So you can see a good example of that here. This should have a scoop. How I explain this to patients is we have a bump, and what we want to do with surgery is we want to make it a scoop. So as it comes up and as your hip rotates, there's room for that hip to come up, and it doesn't impinge, causing symptoms, causing damage to the labrum, damage to your cartilage. And then the final x-ray that I would typically get would be a false profile view, and that's something that helps us look at the anterior acetabulum, helps us to identify how much coverage there is in the front part of the socket, and helps us identify that subspine region, which is the region kind of right below the attachment of the rectus muscle, which is kind of this area right here. So this is a patient that would need some bony reshaping in this area if they did have symptoms coming up from there. And then I'm just going to go through a couple examples of x-rays here just to give you an idea of what some of these look like. So on the right, you can see a good example of a dysplastic hip or hip that has a very shallow socket. And so you can see that the center edge angle, which is the red line, is very small. So normal for that would be sometimes or somewhere below 25. And you can see a widened space medially. We can see a retroverted acetabular socket, or a socket that's more tilted to the back. And again, that's going to have more tendency towards a pincer type deformity and have a shorter distance for that hip to come up in flexion before it engages that acetabulum. You can see narrowing or arthritic changes. So there's some narrowing here of the lateral aspect of the hip, and that's arthritis. And that's important to identify, because those are patients who, in the literature, don't have worse outcomes with hip arthroscopy for treatment of this. We can see that there's some lucency of the femoral head, and this is a sign maybe there's a problem with the blood supply or osteonecrosis of the femoral head. We can see there can be damage or ossification of the labrum with repeated stress that can form bone in that area. Or we can see osteophytes on the femoral neck side, which we can all tell based on just simple x-rays. And then this is just kind of something to show, a lot of times it will look normal, and often in retrospect, we can see that maybe there's a small area of a problem here at the calcar on the left side. But really, this is something where advanced imaging will identify more of these problems if we don't see anything on the x-rays. So the take-home of all this, and it's a very busy slide, is that we can learn a lot from the x-rays. We can help classify these patients as to what type of impingement they have. And then ultimately, it can help guide us to treatment and try to understand how we can help get them better. Putting all of that into perspective, though, is very important. So there's a number of things that that we have in orthopedics that just because we have an image that shows something, it does not mean that that's exactly what's causing that patient's symptoms and causing their pain. And certainly FAI is one of those things. There's been a number of studies that have looked at the radiographic findings of FAI in asymptomatic patients and found a high percentage of those. And again, this is something I think we're still learning what the long-term effects of this means, but this was a study out of Utah, University of Utah, that looked at 67 of their football players who all had asymptomatic normal hips, and almost all of them had one finding from a radiograph of FAI. And this is the challenge where we have to kind of combine physical exam, history with our imaging, because just because someone has imaging or comes in with an MRI finding of a labral tear doesn't mean that they have to have surgery or they have impingement. Some of this may be, they may have no symptoms, and we have to kind of be able to parse that out when we take care of those patients. And again, this is just kind of the data from that study. So if we call their alpha angle or the measure of the cam normal above 55, you can see that a vast majority of them had numbers that were above that. And then same thing from the acetabular, the socket side, where we looked at the center edge angle. There is a number of bony problems with femoroacetabular impingement. Some providers will get a CAT scan. Most of them will do like a low dose radiation protocol for this. Typically, I don't do a CAT scan for this, but some providers will. And then really, an MRI is something that is helpful, not as much from a diagnostic standpoint, but really more from a planning surgery and a therapeutic standpoint. So there is some debate as to whether you would need to inject dye or do an arthrogram with your MRI. Typically, if it's a 3 Tesla magnet, you don't have to do an arthrogram. But if the patient has not had an injection yet, they've failed conservative management, they've done around significant physical therapy, they've addressed their activities, it's a nice time where in addition to the contrast, you can inject lidocaine, you can inject a steroid, and you can get a diagnostic information from that as well. So often I'll do that if the patient has not had an injection before. I'll combine that with getting the MRI when we do. Again, this is just one more study that as you get these MRIs, you're going to get these findings, and you have to figure out, well, what do we do with them? So this is a study out of where I trained with Dr. Philippon that looked at 45 asymptomatic volunteers. These people had no problems with their hip. They were given some money to go into the MRI scanner, and they found that, and the average age was 38 for this study, and they found that almost 70% of these patients had a labral tear that could be identified on MRI. And so we have to marry the clinical exam, we have to marry the history with these imaging findings, because if we just look at the imaging, a vast majority of patients will be overtreated who don't ultimately need something surgically done for this. And then this is just a study that had looked at really the value of this. So as we talk a lot about value in medicine today's day and age, most patients could have a good diagnosis based on just exam, history, x-rays, and an injection, rather than adding an MRI or any other advanced imaging. And it's important to realize that not all MRIs are created the same, so we need them to be protocoled in the right way, and this is why often we'll try to order them in a specific manner so that we're getting cuts actually through the labrum so we can identify that. Often MRIs will look like they do on the left, where if it's not protocoled along the neck of the axis of the femur, then we get much different images. So how the MRI is done may explain some of the results that we're getting from this as well. I thought it would just be interesting for you guys to see a little bit of the findings that we see on some of these MRIs. So we can see cysts that develop around the labrum. So when you have a tear, which you can kind of see right here, this white area is actually fluid from the joint that's escaping around the labrum, and you can have a perilabral cyst that develops from that fluid as your body tries to encapsulate that there. You can have herniation pits, which are benign findings of the femoral head-neck junction. You can have subchondral cysts, which is fluid that can track underneath of the bone, which is more of a harbinger of some arthritic changes in that area. There can be changes to the blood supply to the femoral head, which we see in osteonecrosis or AVN or avascular necrosis, which are multiple ways to say the same thing. And as we showed earlier, you can see a stress fracture on your MRI. So it's not that it's not helpful, but we have to kind of be able to combine this with what we know about the patient's exam and their imaging. And then ultimately we put this together with the treatment. So we have a patient in front of us who has hip pain. We have x-rays that kind of show that they have some signs of impingement. what do we do with that patient? Certainly the vast majority of patients, really all patients, should begin with non-operative management. And many of this is started either by themselves or by other practitioners that they're seeing. And that involves time off from the activity that's causing their symptoms. So that's rest, which is really hard for a lot of us to do and hard for a lot of us to get our athletes to do. It involves physical therapy. And really the goal of physical therapy is to retrain a lot of the muscles that tend to have been weak because of the intra-articular pathology that's going on. And it's important to remember that if the pain, the problem's been going on for 6, 9 months, years, you're not going to fix that with a week or two of physical therapy. It needs to be a significant amount of therapy. Typically, I like patients to go for minimum of 4 to 6 months of therapy to really see a good benefit and know whether or not that's something that they're going to have relief from. Anti-inflammatory medications and then ultimately injections is really the step that I think is also helpful from therapeutic but also diagnostic standpoint to make sure that we're treating the right thing. So non-operative management involves strengthening the glutes, strengthening your abductors. Typically we see a lot of tightness, a lot of pain more in the flexors, so your psoas and your adductors, you tend to see more tightness there. And then the lateral and posterior structures, your glute, your abductors tend to be weak, so we have to work a lot on that with therapy. And then we have to also address everything else. So they tend to have pain, tend to have weakness in their core, their pelvis, and all of this is connected, and all of this can, downstream lead to overload of the hip joint. But I think ultimately as patients go with therapy and we try to see whether or not they're getting better, it's important to understand that there are patients that have the bony anatomy that's predisposing them to impingement, and we can't fix that with therapy. Those are patients that if we've done the appropriate course, we've worked them up, and they've gone to months and months of therapy, if they're still not getting better, we would need to see them back and talk about what the next steps would be. But ultimately, therapy is a huge part of this diagnosis. It's a huge part of the treatment. And if you were going to consider surgery for this, it's also a big part of the recovery after surgery as well. And then finally, we don't like to practice like this, but certainly insurance companies want to see that you've done documented physical therapy before, approving the next step, and so that's something that we have to keep in mind as well. We kind of talked about this again. Many patients will get better with therapy alone, but it's not a week of therapy, and it's a dedicated amount of time that they have to put forward to treating this, and often that's usually 3, 4, 5, 6 months of therapy that will help. If that doesn't get them better, my next step for treatment would be a diagnostic injection. Again, this can be done at the same time of an MR arthrogram, or if they've already had that, this can be done in the office under ultrasound guidance. Typically that would involve both lidocaine as well as a steroid to help with their symptoms, but the important thing is that we combine that with an exam right afterwards. So we want to see, does this help with their pain? Did they get relief from this? If they have 90% relief, then that's a home run that, hey, this is exactly what's going on. They'll do very well if we address the bony pathology. If they have almost no benefit, it's not that they can't have impingement, but we have to really step back sometimes and say, are we really looking at everything else that's going on, or are we missing something here? And then, I want to go through a couple studies that looks at, the treatment and how successful each of these options that I'm going to propose to you really is. So, this is looking at non-operative management of FAI. Importantly, this was done at a children's hospital, so the age range of the patients involved was age of 10 to 21. But they had a randomized control study. It's a level 2 study that looked at all patients that came in. They broke them down to initially treating with non-operative management, so therapy, rest from their activities, activity modification, and then if those didn't get better, they would bump them up to the next part of the study, which would be an ultrasound-guided injection. And then of those patients who didn't get better after that, they would treat with surgery. Ultimately, of the population they were treating, over 80% was able to be treated non-operatively. So certainly for adolescent population, and this would be what my experience would be as well, is that certainly for adolescent populations, especially while the growth plate is still closing and forming, we want to do everything we can to treat those patients non-operatively. As patients get older, the success of that is certainly there, but we have some nuances that we'll talk about in a second. But of this population, again, this is where we talk about the bony anatomy. Like, we can't change that with therapy. Of this population, the ones that tend to have not done well with non-operative management and needed surgery were the ones that had a cam deformity or a mixed type picture. And those are the things that we wouldn't expect therapy to really be able to change. But again, the takeaway is that we should start non-operatively. Just because you have a labral tear, you have evidence of impingement, does not mean you have to jump right to surgery. And most patients, obviously that's what most people would want to do, and certainly what I would recommend for every patient when we start. But as we talk about the operative treatment, we have to kind of understand a little bit of the history of this. So when we diagnosed this and we first started to understand this condition, most of these were being treated through an open approach. So we were doing a surgical hip dislocation, which involves a relatively large incision. You go down and you kind of expose the hip joint, and then you actually dislocate the femoral head out of the acetabulum. You can imagine that's pretty big surgery and has complications and has a recovery time. And this is just kind of an example of, we can shave down the bone, but this is a big surgery to do. And we can do that much more minimally invasively now and have the same results with a hip arthroscopy. The one thing I'll kind of back up as a caveat is for a patient who does have retroversion or a dysplastic hip, those are patients that ultimately may need a bigger surgery to actually reorient their pelvis, and that's an osteotomy, which is an open procedure. So those are not patients that typically do well with hip arthroscopy. We began trying to, this obviously I wasn't around in the 30s, but people were trying to visualize inside the joint externally for a number of years. And it's difficult because if you think about your shoulder, it's a much looser joint. We have more, and the reason it's looser is because we have more motion with our shoulder than we do our hip. But to be able to visualize into the hip was difficult because you have to distract the ball from the socket. And that's ultimately was a big kind of aha moment that we had when we were able to do that. In the 30s, we kind of tried, but we weren't able to do it. And most people said, hey, this is really too tough to do. I don't think that's going to work. There's some early cases of being able to do this for infection, but really in the 80s was really when a lot of this advancement has happened. And the advancements happened because we were able to distract the hip. So we were able to provide traction to, you can see kind of in the right-hand side here, you can see the normal hip joint. And then with traction, all of this increases our working space to allow us to actually address the pathology going on in the joint. You can imagine that if this is, if the surfaces are together, and again, this is three-dimensional, so we have, a ball that's fitting into a socket. To get instruments in there without damaging everything else is very difficult unless you have good distraction. And that was really the main advancement that we have in the late 80s and into the 90s that allowed us to advance the care of these patients so that we can address this arthroscopically. You can do it either supine or where you're laying flat on the operating room table, or in the lateral position. And again, even into the late 80s and 90s, I mean, these are things that were done really only by experts, and I can tell you there's a learning curve to this. This is something that is difficult to do. And so a lot of providers have tried, but it's difficult to do and to navigate because it is such a kind of curved structure. But this is an example of what surgery and kind of the setup would look like, today. So we need a special traction table. This is the table that I use here, and it allows us to pull traction against a fixed post that's between the patient's legs to distract the hip joint and ultimately give us access to then do the work of the surgery. You do it under C-arm or X-ray guidance, which you can kind of see right here, and that allows you to know exactly where your instruments are so that you're not causing damage to the cartilage. But it can be done arthroscopically. So most of the time, actually all the times it's done with 2 incisions that are about the width of your pinky finger. And the instruments are long enough to get into the hip joint so that you can then do the work of the surgery. And this is just an example of what that distraction looks like here, where you see the vacuum sign that is present as you distend the hip and allow it to move apart from each other. In addition to FAI, there's a number of other surgeries that hip arthroscopy can address. It can address, as we talked about, labral tears, injury to the cartilage in the acetabulum or the femoral head. It can address snapping hips from either the labrum or the psoas, loose bodies, things like that. Those are all things that you can do arthroscopically, which obviously has a shorter recovery time and is more advantageous for the patient. And then in a typical case, what I would do for hip arthroscopy, we go in, we create our portals. We begin by doing a diagnostic scope where we look at everything, we kind of take inventory of what the work that we're going to do. And then we actually do the work of the surgery, which is to do the trimming of the acetabular side or to resect the pincers. So if you have too much coverage of the acetabulum side, the goal of the surgery would be to remove some of the bone so that you allow more space for the hip to come up into flexion. If there's a labral tear, you can repair that with absorbable anchors and suture that goes around it and to repair the labrum back down to bone. And then you address the femur side. And so again, if there's a cam deformity there, you'll reshape that proximal femur so that then as you bring the hip up into flexion, it's not causing impingement and you can take care of that bony anatomy. So this is kind of just an overall treatment that we have for addressing the labrum. And what you do really depends on the type of pathology the patient has. So some patients don't have a significant labral tear and you can just debride those patients. And what that means is you use a shaver to try to roughen up that area and really debride the area behind the labrum. I would say that most patients will need a labral repair, which involves placing an anchor into the acetabulum and then kind of looping suture around the labrum to then heal that back down. And then there are times when the labrum, over repetitive activities, you can kind of see on these videos where the impingement will actually change the quality of the tissue and the labrum's not functioning, then they need a reconstruction, and that's done with either IT band fascia, and it can be your own or it can be a cadaver. And the goal would be to reconstruct that labrum. I think these videos probably are not going to play, so. This was another neat video, but you know, the labrum functions in a number of ways, and the main function that it has is really as a seal and a fluid seal for the hip. So when that's disrupted, when there's a labral tear, that stability of the hip is decreased, and so our goal is to restore that by restoring the seal of that labrum. We can see, get this to move forward. So we can see damage to the cartilage with impingement as well. And this, again, we kind of saw on those earlier videos. And most of that cartilage damage we see with more cam-type impingement. So as that bump comes up and engages the acetabulum, often you'll have a delamination or shear-type forces that happens at that cartilage. And that can, you know, obviously be a big problem over time. That's how we think arthritis develops. As you have continued flexion, damage to the cartilage, those are how we think arthritis develops. Similar to the knee, you can microfracture this. You can treat the cartilage damage that we find, and actually we see better results of microfracture in the hip than in the knee. Some of that thought is that because there's such kind of apposition between the ball and the socket that it tends to have a better result when you're forming that fibrocartilage with a microfracture. But then again, the goal is as we reshape the femur, we're turning that bump more into a scoop. And so we're allowing more range for the ball to come up, and it's not impinging, and it will take care of the bony anatomy here. So again, these videos kind of show that. Unfortunately, I don't think that they will play, but you know, this is a tool we use a burr to reshape that, and that's really what we're doing with surgery. We're reshaping the acetabular side, reshaping the femoral side to allow increased distance, increased area, so that when you come up into flexion, it's not causing impingement. Okay, so this is a good example kind of before and after. You can see that this is that cam lesion here, where we have the bump. And then afterwards, we have a normal offset of the femoral head as it transitioned into the femoral neck. And so you can imagine as that comes up, we have more room and we don't have impingement. So that's the basic goal of what we're trying to do on the femur side with surgery. Yeah?
You're primarily seeing this in adolescents?
No, this is something we see in all age groups. But you know, the question is, from a surgical standpoint, and that's what I'll talk a little bit in the outcomes, is who can we best help with surgery for this? So there are, go ahead.
Is that occurring because of friction, or is it more like pathology stress? If you're talking about an adolescent, gold, then is that the pathology or barrier stress that's being put on the neck of the femur, or
that's causing the cam deformity? Yeah, so we're seeing that there's thoughts of this, and again, there's a couple different schools on this, but most people think that as an adolescent is active and doing different activities and their growth plates are still open, that if there's too much stress, and again, that's where I can't define for you what that is, that can cause a response of the growth plate. And growth plates know one thing, they know how to make bone. And so they make more bone in response to that. And that's what can lead to this bump developing with, we think, overuse in kind of this adolescent period. Again, that's not set in stone. We don't have that known definitively. But there are a number of people who have this and they go through their life and never have problems with it. But most patients, when you combine this anatomy with an activity at risk, so, a goalie or a hockey player, anything like that that has a repetitive high flexion type activity, those are the patients that tend to have symptoms from this. Simple walking around, you're not engaging this as it comes up into flexion. Most of the time this is flexion above 110, 120 degrees. So most of the time that's not happening in simple activities. But for high level athletes, that's happening commonly, and then they can't do what they want to do if this isn't addressed. So for me, my indications for hip arthroscopy is, first of all, have failed non-operative management. So, this is something that happens after physical therapy. It happens after activity modification, after treatment with an injection. And we want to see that they have a correctable anatomy. They have bony pathology that we can address. This could be a symptomatic labral tear. Again, those are things that sometimes beforehand, but also intraoperatively you'll be able to decide whether or not that labral tear needs to be repaired. It's nice if they have a positive response to an intra-articular injection. It doesn't have to be, but again, I always stop and think back and say, are we missing something? If we inject their hip and we think that's the cause of their problem and they have no benefit, then we have to always step back and say, are we missing something there? Arthritis is a little bit of a concerning sign, and I'll show you the results. Those patients tend to have worse outcomes with hip arthroscopy. And again, a dysplastic or a hip that is a shallow socket also is one that often needs a different procedure and doesn't need a hip arthroscopy. And again, patients have to have realistic expectations. The recovery from this, I usually quote patients somewhere between 6 and 10 months. So this is not a quick turnaround. This is something that requires a dedication of time, requires therapy afterwards. And patients have to realize that. This is not something you're going to get up and go back to running, or playing basketball a week after surgery. It takes time for that. Patients that I always am a little leery of as far as recommending this is patients who have a lot of significant laxity, patients who have a picture of evolving arthritis. So every patient with hip pain doesn't need a hip arthroscopy to address that. Certainly patients that are on preoperative narcotics or their exam or history is just not consistent with what we know about this. And those, again, who have unrealistic expectations are ones we have to always kind of think about, or do we want to recommend surgery for them versus trying to help them in other ways. And then really the final part of this is trying to understand, okay, so we have this kind of newer diagnosis that we've learned about in the last 20 years. We have a treatment for that, but I've offered you a couple different ways to treat that. What are the outcomes? How do we know what to do for these patients? And this is something that I think is growing in the lay literature as well. This was the front page of the New York Times that really wanted to ask, like, where's the evidence that shaving bone on both the acetabulum and the femur side actually helps patients? And we should have that, because we don't want to do treatments in medicine that aren't validated. We don't want to spend money on these things that ultimately haven't shown to be proven. But we do have that data, and that's something that we have come with over the last couple years for hip arthroscopy. So this is a study. Dr. Bird is really one of the forefathers in this. He's down in Nashville, and he presented his 10-year follow-up of 50 patients, of his first 50 patients. 10-year follow-up in orthopedics is very good. Our goal is ultimately as long a follow-up as possible, but 10 years is good midterm follow-up that we have an idea of whether this procedure helps or doesn't help. And so his results were that he had about a 25-point improvement, and we use this scale called the Modified Harris Hip Scale, and that's something that is pretty consistent across these studies. But he had significant improvement, and as you see, most of his patients maintained that improvement as they went out a number of years after surgery. This was a study that was recently published in 2018 that was a randomized control study. So really the highest level of design of a study that we can in orthopedics that compared surgical treatment with physical therapy. This was a predominantly active duty military population. And their findings was that physical therapy was better, or another way to put it was that surgery had no improvement for this type of condition. The problem that most people have with this study is that as you look at their groups as they work them through treatment, 3/4 of their physical therapy group crossed over and wanted surgery. And so ultimately at the end of this, although we randomized from the beginning, we're comparing 11 patients from physical therapy with 63 who ultimately wanted surgery, and it's difficult to compare apples to apples with that. So, this is a study that's out there, but ultimately how much we take away from it, I think, is difficult.